All right, so the topic for today is the pulmonic valve, the new forgotten valve. Actually, it's a nice segue from the rounds last week. As you remember, Mike Rio presented a case that kind of encompassed a bit of the pulmonic valve. And the title is the new forgotten valve. It used to be the tricuspid valve was the forgotten valve, but the tricuspid valve is getting lots of attention. You've seen a number of rounds on the tricuspid valve presented here. So today I thought I'd talk about the pulmonic valve. And actually, in all honesty, I think in a busy echo lab, as we're reading, multiple studies on a regular basis, it's pretty easy to forget the pulmonic valve. And sometimes we fly by the pulmonic valve, and it's worthwhile kind of paying attention because you'll miss things occasionally. So I don't have any relevant disclosures for the talk. Okay, so these are the objectives. I'm going to briefly review the anatomy and echocardiography of the pulmonary valve or the pulmonic valve. Discuss the assessment of the severity of pulmonic valve stenosis and regurgitation. Along the way, as usual, very case-based rounds. I always liked echo rounds to be very case-based. If you're presenting echo rounds and you don't show well over half the slides or echo images, then I don't think they're really true echo rounds. So just to briefly review the anatomy, I think we all know that the pulmonic or pulmonary valve is a semilunar valve, very similar to the aortic valve, 3 cusps, and the nomenclature are right, left, and anterior. The diagram on the right kind of shows the pulmonary valve here, the pulmonic valve here. That's the anterior cusp. This is the right semilunar cusp, which is adjacent to the right coronary cusp of the aortic valve. And this is the left semilunar cusp of the pulmonary valve, which is adjacent to the left coronary cusp. As you recall from anatomy, the non-coronary cusp is contiguous with the atrial septum, which should be above this. And the pulmonary valve lies anterior and superior to the aortic valve. And so we'll see it on the parasternal views as being the most anterior of the valves that we see. The pulmonary root is a final part of the RV flow tract that supports the pulmonary cusps. And actually, the structure is somewhat identical in design to the aortic root. And actually, they're reported to be similar to the aortic valve, actually 3 sinuses. But I think if you pay attention to some of the echocardiograms, you can kind of get the sense of the pulmonary root just above the pulmonary valve cusps. And there's a sinotubular junction, which is a subtle line separating the thin wall of the sinuses from the thicker wall of the pulmonary. Almost very similar to the sinotubular junction that we have for the aortic root. So I think most echocardiographers and sonographers recognize the standard views for imaging the pulmonary valve, the pulmonic valve. So this is the parasternal long axis view with anterior angulation. So this is the RV flow tract view. So pretty nice look at the pulmonic valve. Here, you can see it opening up in systole. Here's the main pulmonary artery here. Here's the RVOT. And here's the color Doppler. You can see the flow axis of the valve. And on this echocardiogram, you actually don't noticeable pulmonic regurgitation. And the pulmonary valve cusps are actually quite thin normally, and sometimes they're actually very difficult to see unless the image quality is excellent. Standard parasternal short axis view. This is a good view to look for branches of the pulmonary artery, the RPA and the LPA shown here, pulmonic valve here. You can see it actually, you can't even see it opening during systole, but you can definitely see it closing in diastole. And you can see the flow acceleration through the RVOT going through the valve there. And of course, we sample both pulse wave Doppler of the RVOT and continuous wave Doppler through the pulmonic valve. And in our lab, the protocol usually is to do CW in both the parasternal long and short axis RV flow tract views, and do a pulse wave Doppler of the RVT in at least one of those views, depending on which view the sonographer thinks is useful. I don't mind having it done in both views. And for most labs, this is the standard views to look at the pulmonic valve. But there are actually a few other views to look at the pulmonic valve. And one of them is this view here. These are the pulmonic valve views on the subcostal. So this is the subcostal version of the long axis RV flow tract view here. And the same patient, I can argue you actually can see the pulmonic valve better on the subcostal views than you can on the parasternal views that we had earlier. So with or without color Doppler, here you can see trace pulmonic regurgitation. And here's a concomitant short axis view through the subcostal. So really very pretty images from subcostal. And on this view here, you can recognize you get quite parallel to flow as well. And of course, when you want to sample the highest grade across the pulmonic valve, you really want to be as parallel to flow as possible to get the highest grade. And very similar to how we interrogate the aortic valve for aortic valve stenosis. So we'll start off with pulmonic valve stenosis, and as many echocardiographers know, you can divide it into subvalvular or infundibular, valvular or supravalvular, and that can involve the main or branch pulmonary arteries. And the stenosis can occur in any of these sites, either in isolation or in series. And how you determine where the stenosis is really identified by careful interrogation. You start off with color Doppler, you see where that flow acceleration begins. And then if you have to interrogate further, then you use pulse wave Doppler to try and localize the pre-stenotic flow acceleration and the post-stenotic signal aliasing, very similar to how we try and identify intracavitary gradients on the left side when we think it's either mid-cavitary versus LVOT, etc. And you really want to use that pulse wave Doppler to localize where that stenotic flow accelerates. And then on top of that, the shape of the Doppler profile may also help you distinguish subvalvular obstruction, which tends to be more dynamic, a bit more dagger shaped, partly because there's contraction of that RV outflow tract as well. That tends to be fairly muscular, versus something that's more parabolic shaped, that's more indicative of a fixed obstruction, which could be valvular or supravalvular. Okay, so and the gradient of pulmonic valve stenosis is very simple, and Mike mentioned this last week. It's really based on velocities, and it's very simple to measure. Mild is less than 3 meters per second. Moderate is 3 to 4 meters per second, and severe is greater than 4 meters per second. And when you use 4v squared, it looks at you come out to a peak gradient of less than 36 for mild, 36 to 64 for moderate, and greater than 64 millimeters of mercury for severe. But there's also, on top of the gradients, you also want to look at additional evidence for pulmonic valve stenosis. And for valvular particularly, obviously systolic doming of the pulmonary cusps is an important indicator that the degree of pulmonic stenosis based on probably the most common etiology of pulmonic stenosis. You can see post-stenotic dilatation of the main PA. And then with whatever degree of pulmonic stenosis, whether it's subvalvular, valvular, supravalvular, if it's severe, then you have the consequences with RV hypertrophy and septal flattening, that RV pressure overload septum that you see. So on the right side, you can see a pulmonic valve, a fairly thin cusps, looks to open fairly well. There's trace or mild pulmonic regurgitation. There's a bit of flow acceleration through the valve. You see here where you localize the flow acceleration. Remember I spoke about the sinuses. Here you can see almost a little bit of a waste here. That if you look at the PA carefully, you'll see this not uncommonly in patients. Sometimes it's quite straight. Sometimes you see a little bit of an indentation here. But if you slow this down, actually you can see there's a degree of systolic doming of the pulmonary valve. When the valve opens, it kind of curls up here. I'm not sure if I can stop it. And sometimes it could be a bit subtle. So with digital echo, you have that ability to. So here you can see the pulmonic valve, when it opens, you can see the flow acceleration through the valve, and you can see how the cusps are curled up. So that's systolic doming. And in this case, the severity of pulmonary stenosis is not severe. This is clearly mild. The peak velocities are just under 2 meters per second, peak gradient of 14 millimeters of mercury, peak velocity is 1.9 meters per second. And as I mentioned before, when you're looking at pulmonic valve stenosis, attempts to be made in multiple views to obtain the highest Doppler gradient. And don't forget that anything that increases flow through the RV outflow tract of pulmonic valve can also lead to some flow acceleration and a degree of velocity acceleration through that pulmonic valve, even in the absence of significant valvular PS. For example, if you have a pre-tricuspid shunt, such as an atrial septal defect, a high volume through the right side, you can get accelerated flow to the pulmonic valve, or other hyperdynamic states, for example, with net forward flow across that pulmonic valve during systole. You can overestimate the transpulmonic gradient, at least based purely on velocities. So here's another patient with systolic doming. Once again, you see a little bit of that waste as well here, that sinotubular junction. The pulmonary valve cusps here are a little bit thickened, but you can see the doming quite nicely, at least of this cusp. And then on the parasternal short axis view, a bit more clearly, you can see systolic doming of both of these cusps here. So here's another unconventional view of the pulmonic valve. So what view of the pulmonic valve is this? Yeah, so this is an apical view of the pulmonic valve and the PA. And the way you get this view is you go to the apical 5-chamber view for the LVOT and the aortic valve, and then you angle up even more anteriorly. And then you can see, so if you just angle from this view, angle a little bit posteriorly, you'll see the aortic valve LVOT crossing this way, and in normal anatomy, non-congenital, the pulmonary artery, pulmonary valve crosses this way if you angle up further. And this is actually quite a nice view, depending on how on axis you are for the parasternal views. This is actually a nice view to get more parallel to flow for the pulmonic valve. And you can see here, you can very nicely see the pulmonic valve doming here on this apical view. This is anterior, just angle up from the apical 5, and I call it the apical 5 plus view. You can see quite nicely on the flow acceleration. Okay, so case 1. All right, so what do we see here? So parasternal long axis on the left, parasternal short axis on the right. So what do we see here? Yeah, so flattened septum, that D-shaped septum, so it's flattened in systole and diastole. Looks like a pressure overloaded right ventricle, and there's another clue that there's pressure overload of the right ventricle. And what's that?
RPH.
Yeah, so
we really call. Like in this case.
No, that's I could say. So you can see how thick the RV walls are. You can see here no, this is that. That's a good example, right? It's a good example. You can see here the RV off the track view here. Clearly severe right ventricular hypertrophy. So this looks like RV pressure overload, and a lot of times we'll say this is severe pulmonary hypertension. Of course, the caveat when you measure the RVSP is you have to rule out significant pulmonic stenosis. So on this patient here, when you look at the RV off the track view here of the parasternal long axis, mildly thickened pulmonic valve cusp, but still fairly mobile. You can see the systolic doming once again here, and you don't really see an opening, and you can see the flow convergence, the flow acceleration that really occurs at that valvular level. And because of the systolic doming, the opening is probably a little bit superior to where the annulus of the pulmonic valve is. And of course, you have to interrogate with CW. And just a zoomed up view here, beautiful doming of that pulmonary valve cusp. Look at the gradient with continuous wave Doppler across the pulmonic valve. Velocities, well over 5, almost achieving 6 meters per second. Peak gradient of 143 millimeters of mercury. This is clearly severe pulmonic stenosis, and obviously the cause of the severe RV pressure overload that you see from a 2D perspective.
Do you recall how old the patient was?
They were in their 50s actually. Yeah.
And previously unrecognized?
And actually underwent valvuloplasty. Did okay, but the mean gradient only the peak gradient came down, I think, into the 40s or 50s, into the moderate range.
I'm just wondering if there was a bit of a range super valve.
It's true.
Some of the turbulence like it got accentuated, but you see that range.
No, the only caveat that I looked at, because in my reading I didn't realize that there were sinuses as well. But with that doming, they kind of coincides almost in the same area, so it's really difficult.
Even on the mild one you showed it, you can see that when it domes, it comes where the waist is, where the sinotubular junction.
And that makes sense because that's the anatomy of the pulmonic valve. It's very similar to the aortic valve, where the cusps actually go up to the sinotubular junction. That's the support apparatus of the semilunar valves, right? So, and the other thing to mention is that we know that you get stenosis of the alveolar tract in multiple areas. So to have both valvular and supravalvular is not necessarily unusual, right? Okay. So here's that doming of the pulmonary valve cusps here. Let's go back. So here's that the apical view of the pulmonary valve again, and this is, whenever I see the sonographers do this view, it's like it warms my heart, right? Because it shows that it's not a standard view, so it just shows that they're kind of thinking about how best to interrogate the pulmonic valve. You see this trace PI here, and here the leaflets look fairly mobile, but you can see a bit of the waist. And in this case here, kind of to Tom's point, when we use pulse wave Doppler to interrogate, so here's RVOT, here's through the pulmonic valve, here's to just above the pulmonic valve where that ridge was, and here's even more superior to that. So here, the flow acceleration is highest at where that ridge is. So this is supravalvular. This is mild supravalvular pulmonic stenosis. So in terms of etiology, the most common is congenital, as we all know. It could be isolated valvular PS, where you see that dome-shaped pulmonic valve, that systolic doming. You get commissural fusion, which adds to the stenosis. Probably in that severe case, there's probably significant commissural fusion. The valve could be dysplastic, could be thickened, almost myxomatous-like, often seen in Noonan syndrome, which Mike mentioned last week, or it could be part of a complex congenital heart disease realm, such as tetralogy of flow, double outlet right ventricle, which I'm not going to get into today. I'm not a congenital echocardiography, and I wouldn't want to speak to that. The rare causes are more acquired, whether it's carcinoid heart disease, that's serotonin-mediated plaque deposition, that can affect primarily right-sided valves, unless there's an intrapulmonary shunt or metastasis to the lungs. Rheumatic disease rarely can affect the pulmonic valve. It's the valve that's affected the least commonly with rheumatic involvement. It could be iatrogenic, post-surgical, or it could be infective endocarditis related. So let's talk about pulmonic regurgitation. Time is good. So this is, if you're interested, this is a nice review just very recently published last year in Cardiovascular Imaging on multimodality imaging of the pulmonic valve. And these are some of the criteria that's been used for evaluating the severity of pulmonic regurgitation. Color Doppler is really the go-to for examining the pulmonic regurgitation severity, but there are other things that you need to add on to that to really define things better. Very, very similar. You can see the similarity between assessing the severity of pulmonic regurgitation with that of severity of aortic regurgitation. So here, the jet width ratio to pulmonic annulus is very similar to that aortic regurgitation height to aortic annulus for the aortic valve. So severe greater than 0.7. If you do continuous wave Doppler across that pulmonic regurgitation, there's a soft, non-dense jet for mild, a dense for moderate, and a severe pulmonic regurgitation. You get a dense jet with that early termination of diastolic flow, that equalization of flow between the PA and the RV. That represents a severe pulmonic regurgitation. You can measure either deceleration time or half time, which tends to be quite short because that rapid deceleration. There's this PR index, which is the duration of the PR signal divided by the total diastolic period. Most non-severe pulmonic regurgitation, there's still a flow that occurs at the end of diastole, and obviously we could use that to estimate PA diastolic pressure using the Bernoulli equation. And if you quantify it, you can look at regurgitant fraction. And then something that I think we don't do as often as we should when there's severe pulmonary regurgitation is look for diastolic flow reversal in the main or the branch PAs, very similar to what we do for the aortic valve. And you can imagine very similar to the aortic regurgitation. If you see whole diastolic flow reversal in the abdominal aorta, it's a very specific sign of severe aortic regurgitation. So if you see diastolic flow reversal in the branch PAs, then that's probably very specific for severe pulmonic regurgitation. This is the criteria for CMR, cardiac magnetic resonance imaging, which is really the gold standard for quantification of pulmonic regurgitation. What they use the majority-wise in adult congenital heart disease. So a couple of points about assessing pulmonic valve regurgitation. So determining the severity of PR by echocardiography is usually fairly simple, but it also can be quite challenging. And there's also a tendency to underappreciate or underestimate PR severity, particularly using color Doppler. And I think as echocardiographers, we would like to be more specific when we call severe pulmonic regurgitation. The pulmonic valve should always be evaluated with careful attention and have a high index of suspicion, especially if there's unexplained or progressive right ventricular dilatation. If you see that right ventricular volume overload, then really look carefully at the pulmonic valve. As I mentioned before, CMR is that gold standard. You can do a qualitative assessment of the density of the CW Doppler jet. A faint signal in mild PR, usually much more dense in severe PR. And in PR, as mentioned before, the pressure active is short and flow can cease before end-diastole, as the pressure is equalized between the PA and the RV. The one caveat to this is that last point, which I think is important, is that sometimes you can get early termination of that PR signal in the presence of a very restrictive, non-compliant RV. So that classic dilated RV, non-contractile, very restrictive physiology that has a very steep diastolic pressure volume relationship. And that high RV diastolic pressure will result in rapid equalization, even in the absence of severe pulmonary regurgitation. And that caveat also holds for the left side as well for using AI pressure half time for assessing the severity of aortic regurgitation. So here's a color Doppler view. This is the parasol short axis, RV off tract view. You can see that flow acceleration, aliasing through the pulmonic valve, RVOT. How much pulmonary regurgitation do you think is here? You think it's severe? You think it's mild?
Slam.
It's very brief. It's very red. So Dr. Parker wonders whether that is very loud. I kind of set everybody up because
I can see red in the main PA.
Yeah, I think that's the other clue. You kind of wonder about. You have to slow it down a little bit, but there's a lot of red here in diastole, almost into the branch PAs as well, and that's a signal as well. But the other thing I show this is that if you're going pretty fast, this could be called mild pulmonary regurgitation. I don't think anybody would necessarily disagree with that. The patient is a bit tachycardic, and there's lots of flow acceleration. So it's a bit of that hyperdynamic state, and there's lots of color Doppler, right? There's color splashing everywhere, and if you're reading pretty fast, then you're not sure what the severity of pulmonary regurgitation. So here's color compare. Looking at the pulmonic valve, looks a little redundant. Looks like it closes okay. Very brief pulmonary, a little bit more pulmonic regurgitation you see here, but the clue really is in the continuous wave Doppler. So almost to and fro flow actually in systole and diastole. There's a short deceleration pressure half time. There's rapid equalization before the end of the diastole. But also look at the density. The density of the continuous wave Doppler PR signal is essentially equal to the forward flow. So systolic, diastolic is almost essentially the same. And that this all points towards severe pulmonary regurgitation. I think to nail it down, you can do pulse wave Doppler in the main PA or the branch PAs, and you should see diastolic flow reversal. And then you got to go and interrogate. So why is there this severe PR? So this is, when you look at closely here, I actually don't know the etiology of the part. I was looking through the chart. The patient had cirrhosis, had coronary disease, prior end STEMI, and had heart failure as well. But you can see very minimally thickened cusp, fairly redundant. This cusp, probably the anterior cusp, is closing, but this cusp here, it might be the left, is more adjacent to the left coronary sinus of Valsalva. But you can see how it's essentially fixed and it's tethered in the open position. And there's a 2D gap here that is showing. And that malcoaptation, and that this is the etiology in this patient of the severe pulmonary regurgitation. So I don't think I've ever seen this actually. And this patient was never intervened upon. They had lots of comorbidities that kind of determined their outcome. That was not directly related to the severe pulmonary regurgitation. I think we all know that patients with severe PR can also tolerate this for long periods of time, and the literature on tetralogy of Fallot can kind of point to that. So this is so here's the opening. The systole opens up pretty well, and here's that closure point, that gap. See here, this frozen frame. So really nice example. So the etiology of pulmonic valve regurgitation, the most common causes, post-repair of tetralogy of Fallot is probably the most common that we see in our echo lab. You can see it with pulmonary hypertension, that functional PR due to annular dilatation rarely tends to be severe, usually tends to be more mild to moderate. And of course, if you had an intervention on your pulmonic valve before post-valvotomy or balloon mitral valvoplasty, you could get pulmonic regurgitation. And then there's others less common. Carcinoid can cause both pulmonic stenosis, as mentioned before, but also can cause pulmonic regurgitation. Endocarditis more commonly causes pulmonic regurgitation as opposed to pulmonic stenosis, although you can have quite a large vegetation that can include the pulmonary outflow tract. There's congenital abscess of the pulmonary valve, which I've never seen. You ever seen that, Tom? No. It's been reported. And then iatrogenic, of course. And if you remember, I gave traumatic echo rounds years ago, and we had a case of a disrupted pulmonic valve after blood chest trauma that I didn't put in, but you can see it. It's quite rare. Okay, so let's take a look at some cases. So what do we see here? So this looks like a parasol long axis RV off the tract view with and without color Doppler. Yeah, so there's systolic doming of the pulmonic valve. You see a bit of a waste towards the end, that sinotubular junction, pardon me? Yeah, there's a little bit of dilatation here. If you want a bit about posterior dilatation. The valve opening, it looks pretty reasonable actually, and there's some flow acceleration, but it's not dramatic. So the systolic dome of the pulmonic valve, and the etiology behind this. What's the etiology? Is it congenital? So the clue goes to when you look at the left-sided valves. So you see the diastolic doming of the mitral valve. Patient had a prior mitral valve angioplasty, and actually you can see the diastolic doming of the tricuspid valve. And if you look closely here, actually you can see a bit of systolic doming of the aortic valve. So this is 4 valve involvement for rheumatic disease, and the pulmonic valve is the least involved. So here, in this case, the pulmonic valve doming is related to rheumatic involvement of the pulmonic valve. So the clue is to look at the left-sided valves in this patient. Case 4. What do we see here? So this is like a parasol with short axis, RV off the tract view. You can see a bit of the aortic valve over here. Here's the pulmonic valve, really thickened. Can't see the cusp wall, look a little bit thickened. So I'll tell you, the patient had previous endocarditis and had a pulmonic valve replacement, a bioprosthetic pulmonic valve replacement. So what do you see with the colored Doppler? What do you see?
Some flow acceleration around the valve.
Yeah, so kind of
starting in the RVOT.
Yeah, exactly. So the flow conversion really starts in the RVOT, and you kind of wonder, look how the RVOT squeezes here. That that contraction of the RVOT, and the flow acceleration definitely begins above the valve, goes through the valve here. And here's the this is subcostal, beautiful. So subcostal RV off the track view of the short axis, and you can really see that flow convergence here in the RVT. So well below the valve, but goes through the valve. You can see the ALSing, color Doppler bleed going outside the pulmonary artery. And when you do CW, you see more of that parabolic shape here. Peak velocities 4 meters per second, kind of just meeting criteria for severe. But then on top of that, when you do PW here in the RVOT, you can see that dagger-shaped envelope here. So there's a degree, and the peak gradient is 31 millimeters of mercury in the RVOT. So this is subvalvular related to probably RVH and valvular PS related to degeneration of a previous pulmonic valve replacement. And this patient actually underwent valve replacement. Actually, was sent to the Toronto General to have this done by one of their congenital heart surgeons. And they opened up the infundibulum of the RV to allow a bigger valve to be placed. So this is a really nice looking bioprosthetic pulmonic valve replacement. Really thin cusps. You can see the struts of the valve. You can see there's still a bit of flow acceleration to the valve, probably because there's the degree of RVH. But this is bioprosthetic pulmonic valve stenosis. Okay, case 5. So partial long axis RVL foot track view. What do you think? You really can't see the cusps well. Can you see the cusps?
Something just before the branching. I can see that. That's the valve cusp.
Yeah, so there's a bit of beat-to-beat variability, but you wonder, see here? But they're very tethered superiorly. And you can see the flow convergence kind of begins at the tips. So I color compare or simultaneous imaging is helpful. You can see here, and there's a degree of PI, but it doesn't look very striking. A little bit of red.
They could be carcinoid.
Yeah, so you see how it's kind of fixed in the open position, it's tethered superiorly. So Dr. Parker, what is about carcinoid? So here's the CW Doppler. Once again, the backward flow is as dense as the forward flow. It's triangular, rapid deceleration, flow equalization before the end of vascular. This is severe pulmonic regurgitation. And the clue is looking at the tricuspid valve. So you can see tethered tricuspid leaflets, shortened, immobile, kind of a drumstick appearance. So this is carcinoid. And the mitral valve here looks normal or relatively normal. So this is carcinoid involvement of the tricuspid and pulmonic valve. And of course, you have to do the serology, do the blood tests to make that to kind of nail down the diagnosis and other imaging to find the primary. Okay, case 6. Yeah. So it's the classic St. story. Patient presents with fever, not doing well, kind of a subacute embolism course. So this is pulmonic valve endocarditis. This is the largest vegetation pulmonic valve endocarditis that I've seen. So very big vegetation. And once again, patients a little bit tachycardic, 80, 90 spirited, lots of colored Doppler flow, difficult to quantify the severity of PR based purely on colored Doppler. There's a parashoulders short axis RV foot track views. You can see this large multi-lobe irregular mass attached to pulmonic valve cusps, projecting into the PA during systole and back into the RV foot tract diastole. This is a very large vegetation. You see a bit more colored Doppler flow here, but you're suspicious for severe pulmonic regurgitation just based on the destructive process that you could get with pulmonic valve endocarditis. And here's the CW. So it kind of confirms the severity of the pulmonic valve regurgitation in the severe range. And this is the same case. This just shows you the kind of, it's interesting, it's probably suggests a degree of, how chronic the pulmonic regurgitation was, because this is a volume loaded septum, severely dilated right ventricle. You can see the diastolic septal flattening. I wonder if it's a bit flattened in cyste as well. I can't remember if the patient had concomitant pulmonary hypertension. And you can see on M mode here, you can see contraction during systole, and diastole kind of stays flat. You can see it here on the short axis force. Okay, so good. Finished lots of time. So these are my takeaways. So don't pass by the pulmonic valve. Don't fly by that pulmonic valve because you might miss some key aspects. Look for systolic doming. That can indicate the presence of a degree of pulmonic stenosis. That's usually congenital, but can be rheumatic. You have to key in on the left-sided valves. And of course, whenever you see that RVSP being elevated, signifying a degree of RV pressure overload, just make sure you rule out any degree of pulmonic stenosis, whether it's subvalvular, supravalvular, or valvular pulmonic stenosis, because you don't want to call pulmonary hypertension when the high RVSP is related to severe pulmonic stenosis. For pulmonary regurgitation, just be aware for color Doppler can be challenging in high flow states or in tachycardic states. You want to look at qualitative assessment of the density of the CW jet to go along with your color Doppler. Look for that rapid deceleration, that cessation of flow before end diastole as pressures equalize, and that caveat I mentioned before. Just remember that if the RV is dilated, non-compliant, and you think RV diastolic pressure elevated, you can still see that early termination of that PR signal. But then the differentiator is the color Doppler looks clearly not severe, nice small thin jet. Hopefully it'll have good imaging and the heart rate's not too fast. But also that density of the regurgitative flow as well. It should be, if it's short and ends before diastole, but still very faint, and you're fairly sure that you're well aligned, and just be aware that it could just be related to high RV diastolic pressures. Okay, with that I'm going to stop, but happy to take any questions.